Thank you very much for being persistent and staying with us in a very intense day, which will end with an interactive highlight. We will have a panel discussion with the title on the role of online in youth substance use care in the next 10 years. I'm obviously not Katzy. Katzy and others are unfortunately struck down by Omicron and other health-related challenges. And I would like to, I already had the fortune to be introduced early this morning, and I'm now happy to introduce the two other panelists. Number one is ladies first, Martha Ignacioski. She is a Harvard and University of California, obviously, as in San Francisco trained psychiatrist with board certification in adult addiction and child and adolescent psychiatry in Canada and the US. She's one of 100 physicians with a subspecialty training and clinical experience in the US. She now works in the complex pain and addiction services group program at the Vancouver General Hospital and is also the educational lead for the VGH CPAS services and director of fellowship and off-service post-grad education for child and adolescent psychiatry. That's probably the most important title, Martha, I'm sure. It's at least the longest one. And she is also in charge of the consultation services for youth, high-risk substance use in Children's Hospital. So the Dr. Nick Mathews completed an addiction psychiatry fellowship at Yale and a forensic psychiatry fellowship at UBC. He is a clinical associate professor at the University of British Columbia, and he is currently serving as the medical director for complex mental health and substance use services at the Provincial Health Services Authority and as a forensic psychiatrist in youth forensic psychiatric services beside other important work he is doing. And he is sitting a little bit in the dark because electricity is very, very lowly charged in his area of BC. So that it makes a very nice round for the conversation. So the topic, I think, is relatively straightforward. The interesting thing and why we want to focus in this discussion on the next generation and on youth mental health, because I think that is probably the clearest and obvious challenge, but also opportunity. And I wonder, Martha, whether you would like to kick us off with your remarks.
Sure. Thank you, Michael. And thanks everybody for being here today and for the opportunity to talk with you a little bit about my clinical perspective in working with youth and using online communication. I think that this is a timely topic in that during the COVID-19 pandemic, we have certainly had to shift our roles from doing generally in-person work to providing virtual telehealth care. And so I think the feasibility of online communication and online platforms for patient care has been extensively demonstrated. There certainly are some areas for improvement and uptake in other fields of medicine as well. And part of my enthusiasm for this is because it allows us to have a wider scope, especially into rural areas, particularly in BC and other places around the world. But there's also a very good evidence base, in particular for mental health treatment, for internet-delivered treatment modalities. So for example, in preparation for this topic today, I just did a brief literature dive to remind myself how extensively cognitive behavioral therapy for different psychiatric conditions has been studied. And there's been upwards of hundreds of publications at this point looking at internet-delivered cognitive behavioral therapy. And there's effectiveness for management of depression, anxiety, panic disorder, OCD, PTSD, bipolar disorder, chronic pain, phobia, and also effectiveness in treating medical illness with other psychiatric comorbidities such as diabetes. And this has been found to be both cost-effective for patients and the healthcare system. As we transition a little bit into thinking about substance use in particular, there are available prevention programs that have been primarily initially in school-based systems, but have been transitioned into online delivery systems to promote mental health and delay substance use through learning coping skills, setting long-term goals, and towards helping youth achieve those online. So I think this is it's a very important topic. I think we need to think a little bit about how we overcome any existing limitations or barriers in accessing treatment, and virtual care provides some of that. And I'll be happy to share some of the feedback I've gotten from youth and adults that I've worked with through virtual platforms as any questions come up. Thank you.
Thank you for kicking us off. And Nick, why don't you just follow?
Sure. I can speak about my experience using virtual health in the correctional and forensic setting. So when we look at virtual health, we can say, well, it might not be as good as in-person service, but one of the issues is the population density in Canada. We don't have a physician shortage per se. However, we do have a physician distribution issue, where most of the physicians are located in centralized areas, such as big cities like Vancouver, Toronto, and most of the capital. So what happens in more rural and remote areas? And this issue comes into light when we look at the correctional service as well as the forensic service. So currently, one of my jobs is I work online for the correctional health with adults at Kamloops Regional Correctional Center. With this work, I'm providing psychiatric care for patients at Kamloops Regional Correctional Center. I have never actually been to Kamloops Regional Correctional Center. It is difficult to recruit psychiatrists for this kind of work. If you look at correctional health services in general, there's about 7 psychiatrists that provide care for patients in British Columbia, so provincial corrections in the whole province. So without virtual care, most of the patients that would need care would have to go without. So when we look at virtual health, we have to look at, well, what is it in comparison to? Because if in a lot of places, if we don't have virtual health, we won't be providing any sort of healthcare at all. The other place that I work at is the Youth Forensic Psychiatric Service. And so we help set up a forensic rapid access transition team. And so the idea was that we would help patients who have addiction issues in the youth forensic service to gain access to care. So currently there are 6 psychiatrists that serve the entire province at youth forensics. Myself and one other psychiatrist have training in addictions. So if you look at the incarcerated youth, 85.5% of males and 100% of the females met criteria for a substance use disorder. And then when you look at psychiatric disorders, 91.9% of males and 100% of females met criteria for a psychiatric disorder as well. So many of these patients come from underserved rural and remote communities. There's often a long wait list for access to addiction care. They are mandated to receive psychiatric care through youth forensic psychiatric services. And so the idea behind the Forensic Rapid Access Addiction Team was that we could help bridge the gap until they are connected to more longer-term local resources. We have a multidisciplinary team, including nursing, psychology, social work, and psychiatry. We assess and treat the patient's addiction needs and connect them to appropriate therapies, as well as local resources in their communities. So when a patient comes to me, I can help them start on medications such as opioid agonist therapy, stabilize them before handing them over to a community provider. If we did not have access to virtual resources, we would not be able to provide care around the province. And one of the benefits that might come from virtual care is the integration of care. So there was a great study out of Ontario in 2018 that looked at integrating psychiatric care into opioid agonist therapy. And what they showed was that when you integrated psychiatric care into opioid agonist therapy, it led to a reduced ER visit rate, a reduced hospitalization rate, and in Southern Ontario, a reduction in all-cause mortality.
Is there so you working like you're working with youth and in forensic, but would you say that they are, compared also to general forensic patients, that they are more open also to use online tools, and are they using kind of Instagram and all these kind of social media applications, and would they you think it would be easier to engage them using also this new ways of communication?
I think so. I mean, when I'm speaking to youth in the forensic service, oftentimes they're using things like TikTok and Snapchat. So if we can engage them using the tools that they're already using, it might reduce one barrier to care. So with this population in general, it's very difficult for them to make appointments. They often have chaotic lifestyles. So oftentimes we have to meet them where they are. And if where they are is social media sites or social media tools, that's probably what we should be utilizing.
I think that so TikTok is something amazing from my perspective, talking especially about youth. It's an amazing phenomenon for me. In my international work, I came across in Central Asia, I came across a TikTok house which was funded by whom I don't know, and they were producing TikTok videos for Central Asia, and they had about 15 million people kids using that. I was kind of blown away by that. Is that possible? Do you think so? Okay, there are a few more people living in Central Asia than in Canada, but do you think that this would be a way also to organize access to care or access to any kind of support for Canadian kids?
I think so. I think it would be a good way to initially engage patients into care. So if we had online resources, online videos, where patients could be engaged and then sort of funnel them into care. And their first point of contact might not be somebody in a stuffy office, but it might be through chat or video message using these social media tools or another online platform. Mm-hmm. What do you think?
I will say, I think Vancouver Coastal Health has already tried to leverage social media a little bit. I started following them recently on Instagram, and for a period of time, they were using stories, which are very brief tidbits of information to convey information about COVID-19 testing sites over the winter and when it was snowing, information about how to reduce risk of falls and fractures. So I think that these are social media platforms that we can leverage both to provide supportive, helpful, up-to-date information for youth and other individuals. We have to be cautious. There's a lot of misinformation and inaccurate information on social media and TikTok. And so thinking about ensuring that these are sort of recognized individuals that are putting out this information and that it's being rapidly and frequently updated, because that can be one of the challenges, in particular for social media, as one of the challenges of some online use.
Yeah. Also, I think there are some attempts, but listening also to a lot of discussion during the conference today, my impression was that the adolescents, young adults, or even our patients in general are not the real problem, that the real engagement problem is more with our colleagues, with professionals, and that they are kind of anxious to lose control or to be replaced or whatever. What are your thoughts and your impressions in your daily work? Martha, you want to kick off?
Sure. I come from a generation that internet was in my home at a very young age. I've had a cell phone since I was in my teens. I trained in the US where I've never used paper medical records, and I'm used to an electronic health system. So I am quite accustomed to being connected almost continuously. And in working with youth, that seems to be the case, in that many youth are sort of ubiquitously connected. We get, I don't listen to the news. I check my social media, Twitter, for news updates at this point. So I think there is a level of comfort and experience that needs to occur for individuals to feel facile. And so, for a provider to feel quite uncomfortable with a platform and not know where to push or how to connect, or, as we see on all of our Zoom conferences, you're muted, I didn't hear you, and connectivity issues. Those certainly can sometimes be frustrations, but if we're comparing that to absent care for individuals who may not be able to attend an appointment because they're meeting you during their lunch break while they're working, or they happen to live somewhere that doesn't have access to providers, I think that those are small and very, very easily overcome and necessarily overcome barriers to best support our patients and our communities.
Mm-hmm. Any experiences in the tertiary care sector and forensics there?
Sure. I agree with Martha. I think I'm the in-between generation. I mean, I had a cell phone first in my 20s, and I didn't have internet until high school, I think. So it was newer for me, but I think the biggest predictor of whether people in healthcare will adopt the technology would be age. And I think younger people are more likely to adopt these technologies, whereas I think older people not be as likely. However, if you look at what's happening in British Columbia, they have the adoption of various electronic medical records. So it is marching in that direction. There are a few people dropping out of practice because of it. However, the vast majority of people are taking up this technology. And I think if these modes of technology are implemented, I think the vast majority will take them up. Some begrudgingly, and some will be more eager, but it is the right direction to move in towards.
So in general, you're not too concerned about your colleagues in kind of slowly becoming engaged?
I mean, before the pandemic, how many people had been on a Zoom meeting? And then everyone had trouble with it at first. And then now it's how we go about things. And nobody commutes to meetings anymore. We're all doing it this way. And it seems like the more time efficient way, and it's probably better for other things like the environment as well.
Yeah, I agree. Agreed. It's efficient, but it's also a very different way to approach services, and I think we're still working on how to adapt to that. But that said, if I may bring it back to youth a little bit, Nick brought up the very courageous assessment that there is no shortage of specialists and physicians in the field, but so a problem with distribution. The question is also what do you think? How to make use of new technologies to build expertise, to provide expertise, and to make access to expertise easier. You said we already have all these Zoom meetings, we have all kinds of other technologies. Do you think that we have a system in place in BC and other parts of Canada to make access easier? Is that a systematic, is there a systematic strategy also how you are addressing your clients? Are you chatting with your clients? Are you FaceTiming with your clients over day? Or so how are we doing from your assessments and reaching out to the patients, especially those who are special needs clients, like, let's say it that way? Now Nick is shocked. Martha is so okay. Yeah, Martha, start.
Sure, I can start. So I will say that as part of my role at BC Children's Hospital, we have been providing mental health and substance use assessments to the interior of BC as well as to the north. So locations that we previously required child and adolescent psychiatrists to travel to, they would be there for a finite period of time. And so in some ways that the existing system and use of Zoom and other online platforms has allowed for sort of more seamless care. I think the pieces that are missing is really thinking about how do we develop buy-in from our target population. I've been a little bit surprised in some clinical encounters that teens who I've worked with have maybe indicated that they don't at times find online platforms or virtual connections to be a preferred mode of delivering care. And that's sort of been a little bit variable. I've had some youth that really like it for the convenience of it. They can have a shorter visit. It's not as time consuming. And so that can be really helpful. And others that found that sort of the commute after the visit was an ability to process the content that we went over in session. And so disconnecting immediately and diving right back into your regular work day, or doing homework or other things has been a little bit more of a challenge. So I think we have existing systems. We're certainly using them. I think that there will be some flexibility of care after the COVID pandemic. I don't know if we can still say that anymore, but as the COVID pandemic and we return to more of a state of normalcy, I think we will continue to use online healthcare, but it will be more integrated into providing in-person care as well. And it'll be likely a combination of this. And I think that there's some advantages to both.
Nick, you want to add something?
Sure. I mean, I think the biggest issue right now in healthcare is the disconnect between the various care providers. So whether this is inpatient care or outpatient care, housing, pharmacy, labs, care teams, social work, allied health, often these disparate elements work in silos and do not share information or resources. We live in a large country, and virtual health can bridge some of the geographical divide between these resources. So I work at the Redfish Healing Center for Mental Health and Addiction. It's a 105-bed purpose-built hospital for the treatment of concurrent mental health and substance use disorders. One of the issues that we're finding is that we do really good work stabilizing patients while they are at the center, but after discharge, they often go home to their home communities, which are often under-resourced, and the patients relapse or otherwise destabilized. That's why we're working on building virtual capabilities so that we can provide follow-up for our patients once they go back to their home communities. Also, once we have developed that, we're also looking towards providing virtual consultation for the province. And I think if we look at integrating places that have a high level of expertise and resources to places where they have a low level of resources and expertise, that bridge can help benefit the patient experience. And in similar ways, we can develop a program like this for youth with concurrent disorders.
So so access is obviously a critical thing. But now, looking at a little bit more into the direction of a vision, what would for youth mental health care and youth substance use care look like in 10 years from now? I know Nick is especially thinking about the next 3 years, and his kids are not, let's say, in adolescence, or not quite. So if you would imagine also your your work right now. So because that should drive our kind of our ideas and our things. So what would be your vision or your expectation for especially youth mental health care in the next 10 years? Is beyond access, beyond virtual consultation? So I'm more thinking about the direct patient interaction.
I think we need to think bigger. I mean, Martha and I spoke about some of the deficiencies in the current system. I think we need to have some sort of online platform that could connect partner housing, labs, pharmacy, case management teams to a multidisciplinary healthcare team that would have GPs, nursing, NPs, psychiatrists, pain specialists, infectious disease, all kinds of physicians or specialists that would be necessary. The platform would allow for integrated care that is easily accessible, has shared documentation, and that could collect data so it could be outcome driven. You mentioned this with social media, but I feel like if we had a platform like that, patients could self-access this platform or be referred to the platform where they could be engaged in online videos. And then that would explain the platform and provide online resources and video chat as needed. Once patients are consented into treatment, they can be engaged by the multidisciplinary team. The team work with the patient to come up with individualized treatment plans based on the patient preference and start them on pharmaceutical and psychosocial treatments that are tailored to the specific patient. This would allow for easy access to addiction treatment and other specialties such as psychiatry, pain, and infectious disease. And then patients could communicate to all the members of the treatment, housing, pharmacy, and lab teams, and have access at all times to their own information. We could integrate psychosocial supports such as cognitive behavioral therapy, like Martha mentioned, and other online programs. And it would allow for a much greater degree of continuity of care and allow patient choice to guide treatment in a more integrated and holistic manner.
I really hope that happens in the next 3 years and not in the next 10 years. You're probably not surprised that I'm kind of really into these ideas and which is kind of pretty much directing us towards a paradigm shift in not only in youth mental health, but also in mental health care in general, or in healthcare in general. So yeah, because the clients we are seeing are all also coming with chronic pain, coming with infectious disease, coming with all kinds of issues, and don't have access to primary care. That's true. May I name? So there are a few questions in the chat. So I just read them for you. There is very much challenges in the north, limited and unstable access. From our lens, we are open to it, but our greatest problem is the workplace openness. So that's from Katharina from Ludwig Forensics, Katharina Ludwig, and from Forensics Prince George. Any comment to that, Nick?
Sure. I mean, unfortunately, people are resistant to change. And I think when you have a paradigm shift in how things should be done, sometimes, unfortunately, that does have to come top down. So I'll bring up CST in Vancouver Coastal Health, and it's going to be Meditech in Fraser Health. And I'm not sure what the other health authorities will be using, but the implementation of an electronic medical record was a top-down decision. And so sometimes it will need to be done to have these paradigm shifts.
Okay, but it sounds a little bit that they colleagues in Prince George don't even have internet. But that's not true.
I think she was speaking to workplace openness.
Okay. Okay. So Anna, Martha, you need to unmute. Yeah.
Oh yeah. Am I unmuted?
Now you mute. Now it's fine.
Okay. I was going to say, my understanding is that, internet is relatively accessible. It's really around cost and reliability. and sort of is the bandwidth able to support, doing something like a video call, which, I think that there is a time and a place with there's something relatively urgent to do a phone visit, but I don't think we want to see healthcare moving exclusively in that direction. We don't want to lose the person-to-person contact. And that's what all the available research around telehealth says, is that the visual component and the ability to have a meaningful interaction with somebody is really important. Switching a little bit into the workplace openness, I agree with what Nick has said in that we need a bit of a top-down approach, but I think that what's really helpful is sort of 3 pieces. So first, recognizing that change is hard and trying to learn something totally new is difficult. So patience, teaching, graciousness, and developing buy-in from all stakeholders, I think, is really key. Secondly, I think appealing to individuals' sense of altruism. All of us are in the healthcare system and work with individuals for various reasons, but altruism is one of the biggest drivers in healthcare. And so recognizing that this can reduce access issues, improve care, and really focus on those pieces, and also develop more of an evidence base around this, I think can be really helpful. And then the third point that I was going to make is just around, understanding what the concerns are from individuals that may have sort of some frustrations or uncertainty about these new pieces of technology or this new change. Do they have concerns about confidentiality, about the care that will be provided, or are there other issues that are coming up which will allow us to sort of more directly address those concerns?
Yeah. Anna Burton is sharing her perspective here. The youth enjoy virtual connection to multi-team meetings. It is, after all, their preferred form. How do we unify on how to interact with mobile technology? So what are kind of the best practices in that area? Any comment for Anna?
I mean, currently the technology that we need hasn't been invented yet. So I think we need to, if we are to engage youth, I think we really do need to use the platforms that they already use. And then as the new platform does get developed, or the new ways of doing things do get developed, there should have that in mind, where we can integrate the current popular platforms into this new platform so that we can more readily and easily engage youth.
Do you think, both of you think, that if I would come up with a platform model, or if I would have something which they're using in New Zealand or in Australia, that the teams would be open to try things? Because a lot of things are also trial and error, and you need to test them out before you can make your own judgment. Do you think that is there would be at least a few teams being willing to start something like that and try something like that, also with a chance to kind of adapt to it, or adapt it as a system?
Well, it's interesting. If you look at the approach that, like, say, TELUS is taking, they bought up a bunch of startups that had EMRs, and then they're continuing to run these startups as if they're startups. So they're competing on a ground level, and it's being built from the ground up. And so there's going to be innovations with each of these different EMRs, and eventually there'll be a sort of Darwinism among these different systems, and a good system would come out of this. And arguably that's probably the best way to develop a system, is through tinkering and from the ground up.
But you know that Darwinistic principle number 1 is surviving of the fittest, not surviving of the best.
I mean, in this case, the fittest would be the one that best serves the purpose of taking care.
Okay, well, that's a discussion to be continued. Okay. question from Yuva. Many youth solely reliably connect via social media, Instagram, Facebook, Messenger, and so on. How do you navigate confidentiality, given that there have been many privacy concerns with some social media platforms? Yeah, important point. What do you think?
Yeah, I think it is a very important consideration. And so I think at this point in time, with the existing functionality of social media, this would mainly be used for psychoeducation and accessibility as opposed to for direct patient care. Platforms that have much more protection built in, like Zoom or other things, may be used for patient care. And I think that there's probably an interim step and an interim level of information, or an in-between level of information, I would say, that can be used for reminders. There's a program out of Baltimore, Maryland, for youth with opioid use disorder, and they use text messages, both with the providers, the psychiatrist, the social worker, text message youth patients and their family members reminders about their next appointments, their next injectable naltrexone dose. They're able to immediately troubleshoot if an adolescent is frustrated, by an appointment or a response or something like that. They can transition that into a phone call with somebody that has time right away. So I think that there does require some creativity and some flexibility with how these different platforms are utilized in order to reduce issues with privacy or confidentiality and sort of leaks of information. But I think that can also be addressed with advanced planning and informed consent.
I guess that's also specifically sensitive and forensic, isn't it?
I'd imagine so. I think this is, once again, don't let the perfect be the enemy of the good. And just because we don't have perfect privacy on some of these platforms, we can still use it to, what Martha was saying, to engage patients, to provide psychoeducation. And then we can have patients move on to more secure platforms, such as Signal or things that have more security built into them. But we should try to engage patients where they're at and use the systems that they're currently using.
You need to strike a good balance, and FaceTime is encrypted both times and both ends and others. So yeah, but it's to be aware of that is certainly correct. Another question from Hoover: what are your thoughts on the training healthcare practitioners to use these digital approaches and interventions? Yeah. So how do we need to open up and train people to be able to deal with it? Is there anything happening right now? Is there any systematic training in VGH or in children's or in tertiary care?
So currently we're using platforms such as Zoom. I mean, we had Skype, it wasn't working out great. So we moved to Zoom or Microsoft Teams to engage with virtual health. I think with these—
in general, there's no systematic training to kind of not only use Zoom and unmute yourself, but to have a basic understanding on how new technologies are working.
I think you're right. I think there is a lack of training, and it would be good if there was more done. And I think once the expectation comes in that this is part of the way that we run healthcare, I think there'll be more people that will be willing to take on the burden of training.
There you are. As a director of services, you can do a lot.
I think training is one of the missing pieces right now for individuals who have resistance in the workplace to using these new platforms. It comes from the discomfort and unknown of something new, and how do I use this, and also some of the concerns about confidentiality and privacy that have come up. But I think that if we are having sort of systematic training, education, that can really be an antidote to some of those apprehensions.
So there's again the colleague from Prince George. It will be important to have systems that can also adapt to those with cognitive challenges. Dealing with cognitive impairment. Is there anything you came across, at least in the current practice, or is it kind of unknown territory, right? So far.
So I think that if I think about my youth patients with neurodevelopmental conditions and maybe some cognitive challenges, these are individuals that fall on a spectrum. So some that are very able to use online technology, some that may use augmented technologies for help with speech and communication and other things. And so may actually be very, very well equipped and quite well versed with using online platforms. I'm thinking of some of my youth on the autism spectrum, for example, that have been trained in virtual and online communication using an iPad from very, very young ages. I think we sort of transition to sort of the more severe spectrum in terms of cognitive limitations, for example. That's where we do need to think about having other individuals available to provide support, whether that's parental figures, whether that's support workers, case managers, et cetera. That role becomes much more important. It is important. I think I do wonder about sort of what technologies exist that I may not be available, that I may not be aware of, or may not be available at this time, but could be adapted in the future in order to be much more available for all these patient populations.
Yeah, there are interesting programs to make use of that. The point is, how do we make it also available and train people to use those new tools? So we're approaching the end of our panel. Nick, would you like to kind of give a 2-minute take-home message from your end?
I think when we're looking at any new technology, we shouldn't look at the current limitations as a barrier to begin implementing the technologies. I think especially integrating virtual care will provide a much more distributed, even system that's more available to the general public, and for hard to reach populations such as youth with concurrent disorders. So ultimately, we have to know ahead of time that we are going to run into issues with these platforms, but we have to have the willingness to work through them so that we can reach a better healthcare system that integrates these tools.
Martha, what are your 5 cents?
I would agree with what Nick said. I think this is online care and access and use of technology for healthcare is not going away. So for the individuals that do have hesitation or resistance, they're going to have to get with the program at one point or another, either by self-volition or just by natural changes that are going to happen over time. And I think that whatever we can do to engage the various stakeholder groups, both our patient populations and the individuals providing care, in order to provide feedback about how things are going, what they would like to see, and also integrating that with our future visions and goals is going to be really crucial for the successful and further implementation of these models of care.
Wonderful. I think the discussion, yes, what you mentioned, I think discussion we need to have among us as health professionals, and especially mental health professionals, to become an active part of the development of these solutions, a far more active part. Otherwise, people are offering us something which is not as pleasant as a few of the EMR systems. So we need to be in charge of building and defining content and learn also from other countries which are ahead of our developments, and just copy and paste everything which is good and makes sense. Thank you very much. It was a great pleasure to discuss with you, and we're coming to the end